Good afternoon, everyone. This is Nancy Archibald from the Integrated Care Resource Center, or ICRC. Thank you all so much for joining us today for this Working with Medicare webinar. It's on state contracting with D-SNPs, Introduction to D-SNPs and D-SNP Contracting Basics. Next slide, please. So before we get started, I wanted to go over a few logistics. For those of you who are joining us just by phone, if you want to view the slides, you can do that by logging into Zoom, and you'll find the directions for doing that in the appointment you were sent for today's webinar. To eliminate background noise, we are going to be muting the phones during the discussion. If you'd like to submit a question, you can do that via Zoom using the Q&A feature at the bottom of your screen. There will not be any unmuting of the phone lines during the webinar or at the end for Q&A. So if you do want to ask a question, please use that Q&A icon. If we do not have a chance to answer your question during the webinar, we can follow up with you afterwards. And at the close of the webinar, you'll see a short evaluation survey that will pop up on your screen. If you would complete that for us, we'd like to get your feedback on the webinar and the Working with Medicare webinar series as a whole. So it'd be great if you could just take a minute and complete that. As usual, we will be recording the webinar so you can revisit the presentation or share it with colleagues who were not able to join today. Next slide, please. So today's webinar is part of a series on working with Medicare, and it was designed for state Medicaid staff who are new to state contracting with dual eligible special needs plans, or D-SNPs, and how contracts with these plans can be used to advance integration of Medicare and Medicaid for dually eligible individuals. And so these webinars are aimed at a state audience. They're also useful for a broader audience. However, health plan staff and providers in our audience may also want to visit our sister organization, which is called Resources for Integrated Care. The link to their website is up on the screen. And that they develop and disseminate technical assistance tools for health plans and providers around successful innovations and care models. So the Working with Medicare webinar series contains webinars on 4 topics, and we repeat those annually. We heard from feedback from some previous webinars we had that we were really presenting too much information in moving too quickly in them. So in response, we have tried something new this time around. We're breaking the webinars into 2 parts. So part 1 today and part 2 will be on Thursday, and that is on how states can use D-SNPs to integrate care for dually eligible individuals. So it takes this sort of more 101 level information and sort of amps it up to a 201 level. The slides and recordings will be posted to our website on Friday. So after we've had both calls, they'll both be up there, and we'll also send you an email with the links to the slides and the recordings. Next slide, please. So we'll start today's webinar with a review of who dually eligible individuals are and how they've come to their dual eligible status. And then we'll begin to talk about what a dual eligible special needs plan is, and we'll walk through some of the new basic contracting requirements and then new contracting requirements that will be coming into effect in 2021. And we'll have some time at the end for additional questions that you might have. So next slide, please. Today's webinar will feature 4 ICRC staff members: Anna Talumas, Kelsey Cowan, Danielle Pera, and Giselle Torralba. And with that, I will turn it over to Anna for our first presentation.
Thanks, Nancy. Next slide, please. So before we talk about dual eligible special needs plans, Medicare Advantage plans designed for dually eligible individuals, we will begin with a brief review of who dually eligible individuals are. Dually eligible individuals are people who are simultaneously eligible for both Medicare and Medicaid. Now let's dive a little more into detail about both of those programs. Next slide, please. First, Medicare is a federal program, so the eligibility requirements for Medicare are the same regardless of what state you live in. There are two ways someone can become eligible for Medicare. The first is if an individual is 65 years old or older and they have had at least 10 years of employment paying into the Social Security program. The employment requirement can be met by the individual's spouse, or in some cases, by an ex-spouse. Another way to become eligible for Medicare is if you're under 65 and have a permanent disability. On the far right of this slide, we have displayed a chart showing the breakdown of Medicare enrollees. As you can see, the majority of beneficiaries qualify for coverage because of their age. Next slide, please. Now, on the other hand, Medicaid is a state-funded program, so eligibility vary by state. It covers a wide variety of eligibility categories, including children and families, people who are pregnant, adults with disabilities, older adults, and other categories. Another important distinction between Medicare and Medicaid is that Medicaid is income-based. Only individuals with low incomes qualify, but states different income and asset requirements for different eligibility categories. Medicaid is a state and federal partnership, and states work with the federal government to design their program to fit the needs of their population. States have some flexibility on what benefits they cover and how much they will cover, but the federal government sets certain mandatory basic rules. Next slide, please. Now, we know that a dually eligible individual is one that qualifies for both Medicare and Medicaid. However, there are two types of dually eligible individuals: full benefit and partial benefit. A full benefit individual qualifies for Medicare and meets their state's Medicaid eligibility requirements. In this case, Medicaid will offer secondary wraparound coverage to Medicare, while on the other hand, qualifies for Medicare, does not meet their state Medicaid eligibility requirements, but does meet the qualifications for Medicare Savings Program benefits. Through Medicare Savings Programs, an individual can get coverage for their Medicare premiums and sometimes cost sharing, but they will not get full wraparound Medicaid coverage. Next slide, please. Individuals, whether or not they are full or partial benefit, what Medicaid will pay in terms of Medicare premiums and cost sharing, and the percent of all dually eligible individuals enrolled in each category in 2019. As you can see in the second row of this table, a qualified Medicare beneficiary plus, also known as QIMBY plus, is the category that has the most coverage and makes up half of this population in the United States. Next slide, please. As of 2019, there were 12.2 million dually eligible individuals. Of those, 71% were full benefit and 29% were partial benefit. 62% of individuals over, while 38% are under the age of 65. Next slide, please. States should pay close attention to their dually eligible individuals because they are a particularly high-need population. This population has a high prevalence of health conditions, functional limitations, and social risk factors. For example, 70% of this population has 3 or more chronic conditions, which can include diabetes, heart disease, asthma, and many others. 41% of them have a behavioral health disorder, such as depression, schizophrenia, or Alzheimer's disease. And lastly, over 40% use long-term services and supports. This means they either live in a nursing home or other facility, or they require help in their home to complete activities of daily living, such as eating, bathing, or dressing. Next slide, please. Because this population has high and complex needs, they also tend to be particularly high cost. Spending on dually eligible individuals makes up about a third of all Medicare and Medicaid spending, even though only 20% of Medicare beneficiaries are dually eligible and only 15% of Medicaid beneficiaries are dually eligible. One way to meet the complex needs of this population that is designed to be both cost-effective and high quality is through dual eligible special needs plans, a special type of Medicare Advantage plan that we will be discussing in today's webinar. Next slide, please. This slide shows all the different Medicare and Medicaid coverage options that are available to dually eligible individuals. Next slide, please. And as you can see illustrated in the middle of this slide, among other Medicare coverage options, dually eligible individuals can choose to receive their Medicare coverage from dual eligible special needs plans, or otherwise known as D-SNPs. All D-SNPs are required to coordinate Medicaid benefits for their enrollees, in addition to covering Medicare benefits. Some D-SNPs may also cover Medicaid benefits or align with Medicaid managed care plans that cover those benefits. We will discuss D-SNPs, highly integrated D-SNPs, and fully integrated D-SNPs during today's presentation. In their most integrated form, fully integrated D-SNPs can often operate similarly to Medicare Medicaid plans and PACE organizations, which are two other fully integrated options for dually eligible individuals in some states. You can see those two options at the top of this slide. MMPs operate under a single contract and receive a blended payment from CMS and states through demonstrations under the Financial Alignment Initiative. D-SNPs, on the other hand, must always have two contracts, one with CMS and one with the state, which we will go into further detail later on in the presentation. We're not going to be talking about MMPs or PACE today, but for more information on those programs, we have several resources on our ICRC website. Next slide, please. Overall, the main takeaway points to remember about dually eligible individuals are that they qualify for both Medicare and Medicaid, that there is a high prevalence of health conditions and high functional needs among this population. They account for a high proportion of Medicare and Medicaid spending costs. And lastly, that dually eligible individuals can choose to receive their Medicare benefits in a variety of ways. Dual eligible special needs plans, the focus of today's webinar, are a Medicare coverage option designed specifically for these individuals. Now I will turn it over to Kelsey, and she will go into more detail about dual eligible special needs plans.
Thank you, Anna. So as Anna mentioned, D-SNPs, or dual eligible special needs plans, are one option for Medicare and Medicaid coverage for dually eligible individuals. In this section, we'll provide you with a brief introduction on what D-SNPs are, how states can leverage D-SNPs to address the needs of your dually eligible population, and which states are currently leveraging this option through a review of D-SNP enrollment trends. Next slide. To begin, let's review what D-SNPs are. So D-SNPs are a type of Medicare Advantage plan specifically designed for individuals who are dually eligible for Medicare and Medicaid. With that in mind, they only enroll dually eligible individuals, and there are several key differences between D-SNPs and other Medicare Advantage plans that support this population, which we'll discuss in just a moment. The D-SNP option was originally authorized in 2003, and D-SNPs began operating in 2006. Since 2013, D-SNPs are required to have contracts with states in addition to holding contracts with the Centers for Medicare and Medicaid Services. This mechanism provides states with an opportunity to define requirements for D-SNPs operating in their states so they can better integrate care for their dually eligible population. This is one major difference between D-SNPs and traditional Medicare Advantage plans, and starting in 2021, new standards were developed for D-SNPs state contracts through the Bipartisan Budget Act of 2018. We'll discuss those new requirements later on in this presentation. Next slide, please. So as I mentioned, D-SNPs are designed for dually eligible individuals specifically. As such, D-SNPs must meet certain requirements that go beyond the requirements of other Medicare Advantage plans. These additional requirements support D-SNPs in addressing the needs of the dually eligible population within a state. So here on this slide, we have a table with a variety of high-level requirements. In the columns on the right, you'll see which requirements apply to D-SNPs and which to other Medicare Advantage plans. And I'll highlight some of the key differences between each type of plan. So as I mentioned on the last slide, in addition to holding a contract with CMS, D-SNPs are also required to hold a contract with the state Medicaid agency. These are known as state Medicaid agency contracts, or SMACs. Contracts with the state govern D-SNP's coordination or coverage of Medicaid benefits. This is another key difference between D-SNPs and other Medicare Advantage plans. D-SNPs cover Medicare benefits, and they also must coordinate delivery of Medicare and Medicaid, which is not a requirement for standard Medicare Advantage plans. In some states, D-SNPs may cover Medicaid benefits in addition to benefits coordination by offering dually eligible individuals an opportunity to enroll in aligned Medicare and Medicaid plans that are offered by the same parent company. Not all D-SNPs do this, in fact most don't, and the extent to which a D-SNP covers or coordinates Medicaid services depends on the requirements set forth in their state Medicaid agency contract. I'll talk a little bit about how states can leverage their SMAC to define coverage requirements for D-SNPs, and Giselle will go into more detail on this topic later on. Additionally, although both D-SNPs and other Medicare Advantage plans may offer supplemental benefits like dental or transportation, only D-SNPs have the opportunity to tailor those benefits to address the specific needs of the dually eligible population. This is because they're only enrolling that population to begin with, rather than balancing those needs with a wider population of Medicare enrollees. Finally, as with all special needs plans, D-SNPs must have a model of care to outline how they will meet the needs of dually eligible individuals. Next slide. So let's talk a little bit more about that model of care requirement for D-SNPs. So as I mentioned, all D-SNPs are required to have a model of care, which is really a framework for how the plan will meet the specific needs of the dually eligible population they aim to serve. Through the model of care, D-SNPs outline how they plan to assess the needs of the dually eligible population within the state, how they will develop individualized care plans, how they will establish care teams to wrap around and provide care for dually eligible individuals, and how they plan to coordinate care across the care team. There are a few additional requirements in a model of care, including the plan's approach to quality measurement, performance improvement, and monitoring health and beneficiary experience outcomes. Models of care are approved by the National Committee for Quality Assurance for periods of 1 to 3 years. Next slide. All right, so we've talked a little bit about what D-SNPs are, how they differ from standard Medicare Advantage plans, and how they use a model of care to better meet the needs of dually eligible individuals. Now let's touch on how states can leverage their SMACs with D-SNPs to enhance coordination of Medicare and Medicaid benefits for dually eligible individuals. So states have a range of options in their contracts with D-SNPs to define coverage and coordination of Medicaid benefits. As I mentioned earlier, coordination across Medicare and Medicaid services is a minimum requirement for D-SNPs. So the base, so to speak, D-SNP contract will include state-set requirements for Medicare, Medicaid coordination without any coverage of Medicaid benefits. The second tier of D-SNP contract sets out requirements for the D-SNP to cover Medicare cost sharing or wraparound Medicaid benefits. And the third and most integrated type of D-SNP contract covers all Medicaid benefits. So we'll talk a little bit about levels of Medicaid benefit integration again later on in the webinar, but I wanted to reiterate that because D-SNPs must contract with the state and also they must cover or coordinate Medicaid benefits, they're in a better position to coordinate care for a state's dually eligible population. In particular, when D-SNPs are contracted to cover some or all Medicaid benefits, they're financially incentivized to maintain and improve their members' health because they're responsible for covering the full spectrum of services that dually eligible individuals may need. Next slide, please. So speaking of the full spectrum of Medicaid benefits that dually eligible individuals may need, here are some examples of Medicaid benefits that states can require D-SNPs to cover as part of their SMAC. These include Medicare cost sharing for individuals that qualify for such coverage, Medicaid services that might overlap with Medicare, such as home health or durable medical equipment, behavioral health and LTSS services, or supplemental benefits such as transportation, vision, dental, or hearing. Next slide. So with the next few slides, I'll review some trends in D-SNP use nationally. So here you can see the percentage of full benefit dually eligible individuals served by D-SNPs in each state as of September 2020. So for example, on this map, you can see that Illinois does not have any D-SNPs, whereas more than 50% of Arizona's FBDEs are enrolled in D-SNPs. It's worth noting that Illinois, for example, has no D-SNPs because they've chosen not to contract with D-SNPs within their state. Instead, they've really focused on using Medicare and Medicaid plans to integrate care for their dually eligible population. Next slide. Here we have the growth in total number of D-SNPs and D-SNP enrollment over time since D-SNPs first began to operate in 2006. So as you can see, there is a consistent uptick in D-SNPs and D-SNP enrollees over time, particularly in the years since the Bipartisan Budget Act of 2018 was passed, which made D-SNPs permanent. Next slide, please. Finally, here we can see national enrollment in a few different types of integrated care plans for dually eligible beneficiaries. So you can see that D-SNPs enroll the second largest population of dually eligible individuals. About 35% of those individuals are enrolled in D-SNPs nationally. Next slide. So to close out our introduction of D-SNPs, here are a few key takeaways. First, D-SNPs only enroll dually eligible individuals, making it easier for them to tailor coverage and coordination of care for that population. D-SNPs are designed to better coordinate care between Medicare and Medicaid through several requirements that go beyond those of standard Medicare Advantage plans. And finally, with one of those additional requirements, D-SNPs must have a contract with the state Medicaid agency, a SMAC, where states can define their requirements for coverage and coordination of Medicaid benefits in addition to the federal minimum requirements. So now I will turn things over to Giselle to discuss D-SNP contracts in more detail.
Thank you, Kelsey. Hi, everyone. Again, my name is Giselle Tralba, and in this next section, I'll be covering some basic D-SNP contracting principles. Next slide, please. So Kelsey touched on some of these points already, but I just want to start off here by emphasizing some key things to remember about D-SNP contracts, which Kelsey noted are also known as state Medicaid agency contracts or SMACs. I want to highlight that states are not required to contract with D-SNPs, and that states can actually refuse to contract with certain D-SNPs or with all D-SNPs. And that contracts must also include certain minimum contract elements. However, states do have some flexibility to include additional elements in their contracts in order to help improve integration for enrollees. Next slide, please. So in the next couple of slides, I'm going to briefly run through the contract elements that SMACs must include. And then I'm going to go into a deeper dive on the first two elements that are listed here. So the minimum elements that contracts must include are that the Medicare Advantage organization must coordinate the delivery of Medicaid benefits, and if applicable, they should also provide coverage of Medicaid services, including long-term services and supports and behavioral health services for folks who are eligible for those services. The contract must also indicate the categories and criteria of eligibility for enrollment into the D-SNP, and it must also include the Medicaid benefits covered by the D-SNP. Next slide, please. The fourth element is that the contract must include the cost-sharing protections that are covered under the D-SNP, and it must also indicate how the D-SNP will identify and share information on Medicaid provider participation. It must indicate how the D-SNP will verify an enrollee's eligibility for Medicare and Medicaid, and it must also include the D-SNP service area and contract period. So not listed here are some new contract requirements coming into effect for 2021, and Danny will describe those a little bit later in the next section. And if you'd like to see some examples of sample contract language, or if you'd like to just take a deeper dive into each of these elements, I really encourage you to visit the ICRC tool that's included on this slide. It is incredibly comprehensive, and it's really helpful for understanding what each of these elements mean and just what exactly they require. Next slide, please. So on these next two slides, I'm going to take that deeper dive into the first two required elements around the coordination of Medicaid benefits and the categories and criteria for eligibility. I'll first review the contract element and then interpret what it actually means. And then I'm also going to provide some additional context that I hope is helpful. These slides also contain some sample contract language that you can include and make applicable in your own SMAC. The sample language is in a green box on these next two slides, but there is absolutely no pressure to read and absorb it now. The sample language is just pulled directly from that ICRC tool that I just mentioned earlier. And again, I really recommend using that resource to get a better understanding of these required elements. So we said that contract element number one must specify that it's the Medicare Advantage organization's responsibility to, number one, coordinate the delivery of Medicaid benefits for individuals who are eligible for such services. And number two, if applicable, provide coverage of Medicaid services, including long-term services and supports and behavioral health services for individuals who are eligible for such services. So this means that all D-SNPs have to coordinate Medicaid benefits, regardless of whether they're covered under Medicaid fee-for-service, by the plan itself, or by other Medicaid plans available in the state. And the contract must say how the D-SNP will coordinate care. So coordination can include a range of D-SNP activities. For example, if an enrollee is identified as having certain functional limitations or mental health needs as identified through a health risk assessment or an individualized care plan, then the D-SNP may have to engage in activities to ensure that they're able to get the LTSS or behavioral health services that the enrollee might need under Medicaid. So this could include determining whether the individual will receive services through Medicaid fee-for-service or Medicaid managed care, and or making those arrangements with the applicable Medicaid program to ensure the provision of those services. It's important to point out that D-SNPs must coordinate the delivery of an enrollee's Medicaid benefits regardless of whether the state provides the plan with information on how that enrollee receives their Medicaid services, although it definitely helps the D-SNP's care coordination efforts if states do provide them with that information. The last point I want to emphasize is that every state with a D-SNP contract will have to deal with this element in some way, and how the state deals with it can range from really simple to really complicated. By contrast, requiring D-SNPs to cover Medicaid benefits, which is related to contract element number 3, is not something that all D-SNPs will have to do. Next slide, please. So again, I've included here for reference some sample SMAC language from the ICRC tool related to contract element number 2. And again, no pressure right now to absorb it. I just included it here for reference. So the second contract element requires SMACs to outline the categories and criteria for eligibility for dually eligible individuals to be enrolled under the D-SNP. So what this means is that the contract must clearly identify the dually eligible population that is eligible to enroll in the D-SNP, and that a D-SNP can only enroll those categories of dually eligible individuals that the D-SNP specifies in the contract. The contract can also include provisions that limit D-SNP enrollment to full benefit dually eligible individuals and or individuals who are also enrolled in a Medicaid plan offered by the same parent company. So this is what we call exclusively aligned enrollment, which Danny will talk a little bit more about in the next section. It's important to also note that partial benefit dually eligible individuals, or those that are categorized as SLIMB only, QI, and QDWI, have some cost sharing requirements that are unlike those who are full benefit. So this means that covering both full and partial benefit duals in the same plan will lead to some members having different cost sharing than others. Next slide, please. So here are some key Medicare dates with some key events that are bolded, namely that Medicare Advantage applications are due to CMS in February. Medicare Advantage organizations must submit their SMAC contracts to CMS by July 1st. In October, the Medicare annual election period starts, and the Medicare STARS ratings for the upcoming year go live, with revisions to those STAR ratings released the following spring. Notice of intent to apply is due in November, and this is something that I'm going to go over a little bit more in the next slide. And then in December, the Medicare annual election period starts. So what's key to know here is that D-SNPs enter and leave states based on the Medicare contracting schedule, not the Medicaid contracting schedule, which may not be the same. Next slide, please. So I wanted to highlight a key date in November, which is the Notice of Intent to Apply, or the NOIA submission. Any new D-SNP for the next contracting cycle must submit a NOIA over a year in advance. So for example, for contract year 2022, a D-SNP must have had to submit their NOIA by last month, by November. Or for 2023, a new D-SNP applicant must submit their NOIA by November 2021. The NOIA must outline the D-SNP's operational plan for the contract year. States can add language to their contracts with D-SNPs, requiring that plans submit a copy of the NOIA to the state and notify them of planned service area additions, expansions, and reductions prior to the applicant notifying CMS. And states with D-SNPs who aren't planning to renew their contract for the upcoming contract year can work with plans to transition enrollees. So states may also wish to review their D-SNP and Medicaid LTSS contracting strategies in light of any anticipated effects of the departure on other D-SNPs in their market. Next slide, please. So that is the end of the section on just some basic D-SNP contracting principles. Some key takeaways that I want to emphasize one last time are that states are not required to contract with D-SNPs, and that states actually have the authority to deny contracts to potential D-SNPs. State contracts with D-SNPs must include minimum contract elements, but states may include additional requirements to improve administrative, clinical, and financial integration for enrollees. And that D-SNPs enter and leave states based on the Medicare contracting schedule, which may not be the same as the state Medicaid contracting schedule. So that concludes this overview of the required elements for SMACs. I'm going to turn things over to Danny now, who's going to talk about some new required contract elements.
Thanks, Giselle. So Giselle just walked through some standard contracting requirements for D-SNPs, but as of January 1st of 2021, there are a couple new contracting requirements that we will be going through today in a little bit more detail. I'm going to start by giving some background on the new integration requirements for D-SNP, as well as highlight some of the differences between HIDE and FIDE SNPs. So recent legislation passed that requires all D-SNPs must meet at least one of two new integration requirements, with the overall goal to improve coordination during care transitions. The first option is to cover Medicaid behavioral health services and or long-term services and supports, which could allow the D-SNP to be designated either as a fully integrated dual eligible special needs plan, or a FIDE SNP, or as a highly integrated dual eligible special needs plan, also known as a HIDE SNP. FIDE SNPs and HIDE SNP designation depends on the level of coverage, which we'll discuss more of in a moment. The second option here is to notify the state and or its designees of Medicare hospital and SNF admissions for at least one group of high-risk enrollees. Again, the motivation behind doing this is to try to improve coordination during care transitions. The first option to meet the new integration requirement, as I just mentioned, is for the D-SNP to be designated either as a HIDE or FIDE SNP. These designations are very similar, but do have some key differences. So the first factor in whether a state can designate a D-SNP as a FIDE SNP or HIDE SNP will depend on whether the state includes substantial behavioral health and or LTSS coverage in its capitated contract with either the D-SNP, its parent organization, or another entity that is owned and controlled by the D-SNP's parent organization. And the second factor is that it will also depend on what entity holds the capitated contract with the state. It's also important to note here that it's the state that decides which standards for carve-outs they would like plans to meet, and from there, the plans will seek designation from CMS through their SMAC. I'm not going to go over the differences between FIDEs and HIDEs in depth, but I did want to note that we included kind of a quick cheat sheet for some of the larger differences between FIDE SNPs and HIDE SNPs in the appendix. Two requirements that are not listed here but are worth talking about, however, are related to service areas and carve-outs. In order to be designated as either a FIDE SNP or a HIDE SNP, there must be some overlap between the service areas for the D-SNP and the affiliated Medicaid plan. However, the service areas don't need to be identical. In terms of coverage, it is required that substantial benefits and or populations are covered. However, there is some flexibility in carving out certain behavioral health services and or long-term services and supports if it's both minimal in scope and if it's consistent with state policy. Again, for those of you who are interested in learning more about this, you can refer to slide 52 in the back of the deck, as well as the resources in the footnotes of this slide. So in addition to the information sharing requirements that we just went over, there are some requirements around having a unified appeals and grievances process, but I want to stress that these are only applicable to HIDE and FIDE SNPs that have exclusively inlined enrollment, which is when a member receives benefits from a D-SNP that's affiliated on both the Medicaid and Medicare side by the same parent company. So for those plans only, there must be a single plan-level grievance process with uniform timelines and procedures, and integration of coverage determination and plan-level appeals. The reason why this is important is because historically, even in plans that integrate Medicare and Medicaid coverage, enrollees still have had to navigate separate processes while filing appeals and grievances. So this requirement is really aimed at alleviating some of the burden and confusion among enrollees. I also want to emphasize that these applicable integrated plans are few in number right now. They only really exist in states that have capitated behavioral health or long-term services and supports and who have implemented exclusively aligned enrollment. We'll be covering more information about exclusively aligned enrollment during the part 2 of this webinar series that is hosted later this week. Now that we've talked a bit about FIDE SNPs and HIDE SNPs, we'll discuss the new requirement for D-SNPs that do not qualify as HIDE or FIDE SNPs. So the D-SNPs that are required to notify the state or the state's designee about inpatient admissions for at least one group of high-risk, full-benefit, dual-eligible individuals. Let's start by talking about how these kinds of notifications are helpful. While considerable progress has been made in reducing hospital readmissions for Medicare beneficiaries, it's well understood that inadequate transition planning and communication failures can lead to readmissions. And for those of you who are familiar with supporting individuals in HCBS settings, it can result in individuals who would otherwise prefer to stay in community settings being admitted or readmitted to Medicaid nursing facilities or repeated hospital or Medicare SNF stays. An improved system for information sharing for high-risk, full-benefit dual eligibles allows for discharge planning that takes all care settings and services into account, a reduction of avoidable hospital and SNF admissions or readmissions, and improved appropriate follow-up after discharge. Ultimately, this leads to improved overall quality outcomes for beneficiaries. This leads us to the goal for this new requirement. So again, effective of January 1st of 2021, D-SNPs that are not FIDE or HIDE SNPs must include a new notification requirement for state Medicaid agency contracts. The purpose of this is to improve care coordination between the D-SNPs and the state Medicaid agency during care transitions. So this does have a flexible approach. States who use existing systems and or health information exchanges, HIEs, the states determine the population, who is at risk, who is high risk, who will be notified, the time frame for the notification, as well as the notification method. The goal of this new rule is to ensure the timely initiation of care management activities around care transitions and in turn help lower readmission rates and more effectively support D-SNP enrollees. As mentioned, states do have a bit of flexibility around how they want to meet these contracting requirements. Let's go through the example of Georgia here. We see that Georgia has determined that their target population, the group of high-risk, full-benefit dual eligibles, is dual eligible members of the DCH Elderly and Disabled 1950C waiver program. So their population is determined through waivers. The members' Medicaid case management agencies are the entity notified in real time through a secure email or secure file transfer protocol. Washington, however, defines their high-risk, full-benefit dual eligible population in a different way. Washington's target population, as defined by their D-SNP contract, is a full-benefit dual eligible D-SNP enrollee who have been diagnosed with dementia, serious mental illness, or traumatic brain injury, and also receive long-term services and support. Their notification method is similar to that we saw in Georgia, but the time frame for notification is designated on a weekly basis rather than no later than 2 days after admission, discharge, or transfer protocols that we saw in Georgia. While each state has a slightly different ways of approaching the new information sharing requirements that go into effect January 1st of this coming year, they are both clearly defined by their D-SNP contract in order to meet their requirements. So overall, the key takeaways here is that all D-SNPs must meet the new requirement for 2021, either through becoming a designated HIDE or FIDE SNP or through meeting the information sharing requirements or of a designated group of high-risk enrollees. The overall goal of these requirements is to improve coordination of services during care transitions, and there's a level of flexibility for states to design their own approach to the requirements that aligns with their individual state needs, populations, or infrastructure. States can modify their process regarding these requirements based on any lessons that they learn from implementation in 2021. So thank you for your attention on this section here. I'm going to hand it over to Nancy to facilitate any questions that you might have.
Great. Thanks so much, Danny. That was really great, and all of our presenters, really great job. I see a couple of people have raised their hands to ask questions, and I wanted to remind folks that we will not be unmuting the phone lines for Q&A. So if you do have a question, please type your question into the Q&A box at the bottom. So we've received quite a few questions that have come in through the chat feature. And I was just going through a few of them. I think one that we can probably take care of pretty easily. I'm going to invite my colleague, Erin Weir-Lakmani, in. It was a question about the deadline for the notice of intent to apply that was in November. That's, again, is for D-SNPs that want to enter a market. And the person wanted to know that if it's too late now for a D-SNP to apply to be in the 2022 contract year. So Erin, can you just quickly go over that?
Yeah, of course. Thank you, Nancy. So as you noted, the deadline, the notice of intent to apply, or NOIA deadline, has passed, but it is worth clarifying, I think, just trying to make it very clear who needs to submit a NOIA again. And so that is D-SNPs who would be new in a state, or a D-SNP that wants to expand their service area. So if there are D-SNPs that would like to enter your state's market for the first time in 2022, they would have had to have submitted that NOIA already in November of this year. Or if you have D-SNPs that would like to begin operating in service areas where they do not currently operate, that's who the NOIA deadline is for. If you have contracts in your state with D-SNPs and those D-SNPs wish to continue operating in the state and they don't wish to expand their service area, those D-SNPs do not actually have to submit that NOIA. So there are quite a few D-SNPs that may continue their operations in 2022 that won't have to have indicated that in November of 2020.
Thank you, Erin. That's a good succinct explanation. Here's another question, and this is a hard concept. The person asked, can we talk a bit more about how the term coordination of care is being used in the contracting context? And she wanted to know, does it mean determining whether Medicare or Medicaid pays for a particular Medicare expense or something different? So I'll start, and maybe Erin, you jump in as well. But so the coordination of care is really can be defined by the state. So for example, if in the D-SNPs assessment that it does of the enrollee, and they identify a need for, let's say, behavioral health services, or that person has some functional needs that they really need long-term services and supports. And we'll say, for example, that D-SNP is not a FIDE or a HIDE SNP, so they are not covering the Medicaid benefit that would address that need, then it is the D-SNP's responsibility to figure out where that individual is receiving their Medicaid covered service and to communicate and coordinate that benefit. So to let that Medicaid entity know that this person needs, for example, supports in the home, and then to make sure that that need is identified. So Erin, do you have more thoughts to add on that?
Yeah, I think that was spot on, Nancy, and I can just share, I pulled up an actual quote here from the calendar year 2020 and 2021 final rule for Medicare Advantage Part D and PACE programs. And in that final rule, CMS noted that coordination, that all D-SNPs now are at least required to provide this coordination that we're talking about today, and that coordination really can encompass a wide range of activities that D-SNPs might engage in to help ensure that their dually eligible members can access and obtain the services that they need, regardless of whether those services are offered through Medicare or Medicaid. And so some of the examples that CMS gives in that final rule really align with some of the things that Nancy just said. So first of all, the D-SNP, for example, would be expected to identify and verify their enrollees' eligibility for Medicaid services like long-term services and supports or behavioral health services. So the D-SNP should be able to tell who within their population might qualify for those services, and then help the person figure out how they would need to get assessed for those services and how to receive them. Those care coordinators within the D-SNP are responsible to make arrangements with the state's Medicaid program or Medicaid managed care plans for the provision of those Medicaid services when they're not covered by the D-SNP. So, when we talk about care coordination, we're often really referring to the coordination of the services that people are receiving and making sure that people are getting the services that they need.
That's helpful, Erin. Okay, another question that came in. My question is related to how the determination of a FIDE SNP service is made, either LTSS or behavioral health. Does the state decide whether it will allow MCOs to offer either managed behavioral health or long-term services and supports, or the plans themselves? Okay, so, but when you say MCOs, I'm assuming that you're meaning the D-SNPs. So for a D-SNP to cover the Medicaid behavioral health or Medicaid long-term services and supports, that decision is made by the state, not by the individual plan. So the state has to allow the plans to cover those services, and it has to be written into the SMAC, the State Medicaid Agency contract with the D-SNP. Does that make sense? And so, Erin, do you want to add anything else in on that?
Yeah, no, I think you got it there, Nancy, that, if the state will not allow the D-SNP or an affiliated Medicaid managed care plan to cover behavioral health or LTSS, then there's not really anything the plan can do on its own to cover those services without approval from the state to do so. So, whoever initiates the conversation about wanting to cover the services in that way, ultimately the state does have the final decision about whether those services will be covered and in what way they will be covered. So if you are a D-SNP and you're interested in covering these kinds of services and you operate in a state where you're not currently contracted to cover those services, I'd encourage you to talk with your state Medicaid agency contacts about why you think it would be a good idea to do that, and initiate those conversations, but know that the state has that decision-making power.
Mm-hmm. Okay, here's another question. Is there a SMAC deadline to begin contracting with the states? And I'm not totally sure what the person is asking, but I'll make a stab at it. And if I'm not answering it, then please let us know in the chat or in the Q&A if this is not answering it. So that July deadline for the D-SNP to submit its contract into CMS. It's actually the first Monday in July. Sometimes it varies, so I think this year was actually July 6th rather than the 1st. But that deadline is, so by that point, the state, so the contract is executed between the state and the D-SNP, and then it is submitted into CMS by that deadline. So I think that's what you mean by the deadline to begin contracting. And then so that's the July deadline, and then the contract year would actually start the following January 1st. So for the contracts that are starting on January 1st, 2021, they were submitted into CMS in July of 2020. So I hope that answers your question. So lots of other stuff in the Q&A box. So let's see. So Erin, I'm going to pull you in on this one because you can probably answer this more succinctly than I can. When a D-SNP is a HIDE SNP or a FIDE SNP, the person wants to know what is, if there's any financial alignment. And by that they mean, does the provider send a secondary claim, or is the plan required to coordinate payment to providers as well? Is that understandable to you?
Yeah, it's a great question. And honestly, it's a great tee up for our second webinar that we'll be hosting later this week. So I hope that, that this person will be attending that webinar as well, because during that webinar, we're going to talk in more detail about the concepts of aligned enrollment and exclusively aligned enrollment, which are very pertinent to this question. And in short, when someone has aligned enrollment, that means that they are enrolled in the same parent company for both their Medicare coverage and their Medicaid coverage. So either they're enrolled in a D-SNP that covers both Medicare and Medicaid directly, or they're enrolled in a D-SNP and a Medicaid managed care plan through the same parent company. And when a person has aligned enrollment, then that single entity, that single parent company, is responsible for both Medicare and Medicaid payment. But that has more to do with whether the plan has this exclusively aligned enrollment or not. And exclusively aligned enrollment is when the state essentially requires the D-SNP only to enroll people whose enrollment would be aligned. So you don't have people in those D-SNPs where they're getting their Medicare from the D-SNP, but they're getting their Medicaid benefits somewhere else. When you do have those misalignments, and it is possible to have a FIDE SNP or a HIDE SNP where at least some of their beneficiaries are enrolled somewhere else for their Medicaid coverage. And when you have those misaligned enrollments, the provider would typically still have two different places that they would have to go for payment. They'd go to the D-SNP for the Medicare payment, and they'd go to this Medicaid managed care plan for Medicaid payment. So it more so than the HIDE or FIDE designation, it really is exclusively aligned enrollment that helps to facilitate that streamlined payment to providers and making sure that one entity can cover that payment rather than having to distribute it across multiple different payer entities.
Great, thanks, Erin. Danny, can we quickly go to slide 47? Thank you. We didn't get a chance to get to all of your questions today. We will respond to individuals offline, And I just wanted to let state folks know that ICRC is here for you for technical assistance questions. You can email us at the address there. And quickly wanted to give a plug, Danny, if you can move to the next slide. Part 2 of this webinar is on Thursday afternoon. You can still register for that if you have not already done so. We're going to go in a little bit deeper dive on some of these contract provisions that states can add in to advance their integrated care programs and deal with things like carve-ins and carve-outs. And we're also going to have a guest, Paul Saucier from Maine, who is going to be talking about what Maine is doing around its D-SNP contracting. This could be interesting for those of you who are in states without Medicaid managed care. That's Maine's situation, so there may be some interesting things there for you. So very quickly, thank you to all of our presenters today. Thank you to CMS for sponsoring the ICRC and to all of you for attending. Have a great rest of your afternoon.